Again, welcome to the last session of the first day of our MPS masterclass. We're basically going to have two presentations in terms of academic colleagues and then a patient presentation at the end. And so my next speaker is Dr. Janey Phelps. She's professor of anesthesia and pediatrics here at UNC. She serves as medical director of the Pediatric Sedation Service, and she'll tell you because of her program directorship of the UNC Global Anesthesia, where she currently is giving this talk from. Janey, my pleasure.
Thank you so much. And as always, thank you for inviting me. This is a conference that every single time I get to learn from the world's experts. So, Dr. Munzer, thank you. I was asked to speak today regarding anesthesia and MPS. I just want to kind of disclose from the very beginning that I am, let me make sure I can still, can everyone still see my slides? Okay, perfect. That I'm actually in Africa right now, and the Wi-Fi can be a little bit sketchy. So I'm going to turn off my camera just so that I minimize the possibility of losing everybody. But if by some chance I do lose you, I apologize and will do my best to get back to you. All right. Technology is usually not my friend, so hopefully it will work. So Kim, I'm having a tough time advancing the slide.
Jamie, you should be able to just normally advance them.
Okay, there we go. I think I had it on pause. Let me try this. Okay, great. So my disclosure slide is none. I hope one day after giving presentations that I'll be able to add something to this disclosure slide, but I have no disclosures. So the objective of this talk today is, at first, I just want to review sedation and anesthesia depths. I think that concept is very important when we talk about anesthesia risk, especially when we think, oh, it's just an MRI or it's just a advanced hearing test. When it comes to the amount of sedation that's needed to perform these tests, it's really important that we're all using the same terminology and have a good understanding of what that looks like. I also want to review airway devices. As you've heard multiple times today, the MPS population can be one of the scariest airways that we take care of as pediatric anesthesiologists. And so I want to just quickly go over some of the different types of devices and the terminology that we use. I do want to do a literature review looking at anesthesia risk and MPS. As Dr. Munzer talked a little bit earlier, anytime that we do have a complication or an anesthesia event, it's really important to try and publish this so it's stuff that we can learn from. And so we'll talk a little bit about what's out there. And I just want to go over some of the take home points. So, in terms of sedation and anesthesia, it really is a continuum. And when we talk about it, we really talk about it based on the patient's responsiveness, the airway, whether or not they can still maintain their airway, or if you need to have an intervention to make sure that their airway stays open, and spontaneous ventilation, whether or not they're able to breathe effectively, or if they need an intervention to do that, and then cardiovascular function. And so now we're going to talk about the different types of sedation. I want to start with minimal sedation. This is also sometimes referred to as anxiolysis. This is similar to giving a patient a midazolam or Ativan, some type of diazepine, just to try and take the edge off. For children, and especially for MPS children, this is usually very, very minimal and would not be enough to achieve the type of procedures and or studies that these children need. Moderate sedation, In terms of responsiveness, this is a purposeful response to verbal or tactile stimulation. And going back to anxiolysis, with anxiolysis, you expect, even though it might be delayed, that these patients are going to have a normal response to verbal stimulation. Airway, spontaneous ventilation, and cardiovascular function will be unaffected. A lot of people think, oh, the patient just needs a little bit of sedation or a moderate sedation to get an MRI. The definition of moderate sedation is that we say, little Johnny, raise your hand, who would be able to raise his hand. So, as you can imagine, that is not going to be sufficient sedation to achieve the studies that are often needed. But with moderate sedation, typically it can be very safe. Airway is usually patent and intervention is not required, and ventilation and cardiovascular function is maintained. Deep sedation is where the majority of pediatric patients, especially patients with global developmental delays like our MPS patients, that's the level of sedation that is actually needed to achieve a lot of the studies that we're discussing. In terms of responsiveness, they should be able to respond, especially following repeated or painful stimulation. They may require an airway intervention and they may need some help with their breathing. Usually, their cardiovascular function is maintained. And then, as a continuum, that moves on to general anesthesia. As we're all aware, general anesthesia, you would have no response even with painful stimulation. Usually, the airway and intervention is required, as well as help with their breathing and/or cardiovascular function. The reason I wanted to discuss this, that based on all the guidelines, if you're providing a moderate sedation, you need to have the technical skills and the knowledge to rescue a patient from a deep sedation, because every patient's different and the medication that you give may increase the sedation to the point that now they're deeply sedated. And since we also talked about the majority of these patients are going to need a deep sedation to achieve this, whoever's providing deep sedation for any patient needs to have that skill set to rescue a patient from a general anesthetic. This is especially important when you talk about children such as MPS, who can be high risk for a number of different reasons. Any sedation, that person needs to have the skill set to rescue them from a general anesthetic. And so let's talk a little bit about the anatomy of the airway, especially the glottic opening or the vocal cords. I know Dr. Molbeck talked about this a little bit earlier, but I just want to reiterate some of the airway anatomy and the things that make us very, very nervous as pediatric anesthesiologists for MPS patients. As you can see, a typical airway, you have a nice passageway from your nose all the way down to your trachea, and then from your mouth or your oropharynx all the way down to your trachea. If you specifically look at the larynx, which you can kind of see to the right, the tongue, that's the base of the tongue, and the very base of the tongue is where you have your epiglottis. Your epiglottis will actually fold over when you're eating or swallowing to keep food from going into your trachea and protect your vocal cords. And then you see the little bumps down there. Those are the arytenoids. And I'm going to point that out in some of my slides a little bit later. This is just a really nice depiction of a normal patient who's having an MRI. As you can see, you see the nasal passage, and it's just the cut between here, but there's a nice opening from the nasal passage down to the airway. And the mouth is also nice and open. And then you can actually see that little, at the base of the tongue, that little tissue protruding out is your epiglottis leading into your vocal cords. I want to compare this to this. This is actually an MPS patient. You can see they actually have a breathing tube in because there's so much crowding in that airway. These are those gag deposits that we talk about. You see them both in the nasopharynx airway. The tongue is large. We call that macroglossia, and just a lot of crowding in that airway. So I also want to talk about some of the airway devices that we'll use when we provide a deep sedation or a general anesthetic. There's this thing called a supraglottic device. It's also referred to as LMA, or laryngeal mask airway. In essence, it's a mask that sits right above the vocal cord, so we can give these patients help with their breathing and sometimes give them inhaled anesthesia as well. It's very helpful to use this when the patient doesn't necessarily require a protected airway, because as you can see, the tip of this will go into the esophagus and the mask itself opens up to the trachea where the vocal cords are. I prefer to use this, especially in MPS patients. If I do need to have an airway, it bypasses all that upper airway obstruction that we talk about in MPS patients. You cannot use it in very long surgeries and or if they have a full stomach or they need to have relaxed muscles for the procedure. This is also a way that we would rescue an airway. So if we induce anesthesia and we can't breathe for the patient, we could place an LMA and bypass a lot of that obstruction that keeps us from breathing. This shows the difference between an LMA, that will be to the left, where it just sits right above the trachea, versus a breathing tube or an endotracheal tube that goes all the way through the vocal cords and sits in the trachea itself. With this type of an airway, you can relax the muscles if you need to. It's really good if it's going to be a prolonged surgery. Part of the reason that I prefer to use an LMA and or just have a native airway in these patients if they can tolerate it is because often, especially in the patients who have severe obstructive sleep apnea, if you put a breathing tube in, it can be very, very challenging to get that breathing tube out. And depending on the progression of the disease, sometimes it could lead to needing a tracheostomy and or needing a prolonged intubation that will end up requiring an ICU admission. To put in that breathing tube, the traditional way is that we use a little metal flashlight with a light to guide the endotracheal tube in. Especially in challenging airways, we would use a video laryngoscope, which is what is pictured here. The nice thing about a video laryngoscope, we can have different types of curves to allow us to get an even better view than we could with our typical laryngoscope that we use. We also can use a fiber optic scope. This is a scope that has little cameras at the very tip, and we could guide the endotracheal tube onto this so that once we get into the airway, we can intubate the patient over the fiber optic scope. As in addition to the cameras, there's also suction ports to allow us to deal with some of the secretions that we might have while we're trying to intubate. I just wanted to go over the different types of airway equipment that we use and some of the techniques that we use. And so why did Dr. Munzer ask me to present today? And what's the big deal with anesthesia? Depending on the study that you look at, it can be anywhere from 25 to 87% incidence of a difficult airway. The only exception to this is MPS 3 because those deposits are in the central nervous system. All other MPS can have very challenging and or difficult airway abnormalities that we would need to deal with as an anesthesiologist. There's up to an 8% incidence of failed intubation, so where we do everything that we can, but we just cannot intubate the patients. The peri-op complication rate has been reported as high as 50%. Usually the literature shows 22 to 23% as the typical peri-op complication rate. And looking at the studies, and this is why Dr. Munzer is encouraging everybody to write up case reports and or case series if we have any abnormal events, is because the literature is still lacking. There's only 193 references in PubMed related to MPS and anesthesia, just with those two keywords since 1967, and most of these are case reports. I like to include this. This is published in the Journal of Pediatric Surgery. And as far as I've been able to tell, this is the earliest reference that I can find looking at an MPS patient. And this reports on a 17-month-old who got the diagnosis of Hurler syndrome around 1 year of age. And this was for inguinal hernia repair. This was a case from 1949, and it ended in cardiac arrest and death. And this was open drop ether, which of course I have not used in my career. But the reason I like to to mention this is they actually summarize by saying, in contemplating surgery for the patient with Hurler syndrome, one can anticipate an increased anesthetic risk due to frequent respiratory infections, airway obstruction, and frequent cardiac enlargement. The surgeon can anticipate a less than ideal response to the surgical therapy due to decreased connective tissue strength. This does not necessarily preclude all surgical therapy, however, because some of the patients have uncomplicated courses. And so, even now in 2025, this statement remains true from back in 1949. So let's talk about some of the MPS patients and anesthesia complications. Some of the major ones is failure to control the airway. There's been multiple deaths throughout the literature from cannot ventilate, cannot intubate. And that's why when I talk about that LMA, that's our rescue way to try and make sure that if we're ever in a scenario when we cannot breathe for the patient, we have a device that hopefully will help us, but sometimes, even with that device, we can be in that scenario. And unfortunately, that has a high chance of leading to either an emergency tracheostomy or severe respiratory complications from that type of scenario. You can have post-obstructive pulmonary edema. You can have arrhythmias, both due to hypoxia related to difficulty in controlling the airway and ventilating for the patient, and their underlying cardiac abnormalities, which has been discussed previously. And there's been multiple reports of intraoperative cardiac arrest. Some of those are respiratory arrest leading to cardiac arrest, and some of those are just cardiac arrest due to the cardiac uh, issues that these patients can present with. In terms of common surgeries, ENT is very common. As Kim mentioned, Cole had multiple ENT surgeries before he even was diagnosed with MPS. These include tonsillectomies and adenoidectomies, ear tubes. As the children get older, they could require tracheostomy, nasal and sinus surgeries. From a neurosurgical perspective, Dr. Elton will speak to this in a few minutes, and that one of the common procedures is a VP shunt. There, Dr. White talked a lot about some of the orthopedic surgeries, carpal tunnel syndrome, joint contractures, and others. Abdominal wall and inguinal hernia surgeries can be common. These patients often have multiple MRIs. Dr. White even talked about wanting an MRI every year to follow the spine in some of the patients, bronchoscopies, cardiac surgeries, dental surgeries. And then this is an older study. It was in 2010, and it sounds like someone may have already mentioned this from earlier, but this is data from 527 patients in the Hunter Outcome Survey. 84% had a surgical procedure. The median age of the first surgery was 2.6 years of age, and most of these patients had up to 3 surgeries, at least that was the median amount. What's interesting to me, especially as an anesthesiologist, is 57% underwent at least one surgery before the diagnosis of MPS. And I love that Kim mentioned that when it came to Cole as well. The anesthetic strategy for patients with MPS, this was a retrospective cohort study. This was published in 2022 out of Taiwan. This looked at 57 patients. It's important to note that 43% of these were adolescents to adults, and they had 151 anesthetics. Difficult intubation was documented at about 12.5%. What's most interesting to me is 40% of these required an ICU admission postoperatively, and I think that's really important for us to make note of. And the majority of these were not planned to be ICU post-op cases. So the reason that I'm here is because I get to work with this young gentleman, Dr. Munzer. Being at UNC, are very, very unique that we see a significant amount of MPS patients compared to a lot of centers. And so with Dr. Munzer and his team, we actually looked at the data in terms of the anesthetics that we have given his patients from April 2014 to June of 2024. We have cared for 65 MPS patients. In terms of total anesthetic encounters, it's 1,215. And as we look through the literature, that is a significant amount of anesthetic encounters where we can actually look at that data. In terms of the types of MPS patients, most of these are MPS 2 or Hunter syndrome, but we, as you can see, take care of all types of MPS patients here at UNC. Procedures performed, most of these were LPs with meds, and that's about 66%. 20% or so had MRIs, neurosurgery 3%, bronchoscopies 2%. The ABR studies, the auditory brain response procedures, about 1.7, and carpal tunnel release at 1.2. Anesthetic complications, and when we talk about these anesthetic complications, just remember this is at UNC with specially trained pediatric anesthesiologists. Even in our hands, the anesthetic complication rate is as high as 23.5%. This is consistent with previous data that shows about 23%. But as I mentioned earlier, some studies show up to 50% of anesthetic complications. We use the definitions defined by the Society of Pediatric Sedation. They have a pediatric sedation research consortium. And when they talk about anesthetic complications, and truth be told, it's often referred to as anesthetic events. We looked at oxygen saturations less than 80% during any period of time. And that occurred in about 37% of the patients that we took care of. Hypercapnia or high end-tidal carbon dioxide, that occurred in almost 36%, which isn't too unusual when you think about the amount of kids who have obstructive sleep apnea that we see. Oxygen saturations less than 90% for greater than 1 minute occurred in about 22.5% of patients. Laryngospasm in up to 4.6%, and post-extubation stridor in 0.3%. The types of airway management that we used, TIVA refers to total intravenous anesthetic with a native airway, meaning that we were able to give IV anesthesia to these patients with a native airway. So they were breathing on their own with a little bit of oxygen and or a small device to kind of open up that airway. We were able, and that occurred in about 32.4%. When we can, we prefer this technique because we don't have to manipulate the airway. Anytime we manipulate the airway, we increase the risk of a potential complication. But with that being said, sometimes we have to safely care for the patients. Mask throughout, meaning our hands are always on the airway using a mask and giving general anesthesia through that mask. We do that a lot for LPs with medications, and that occurs in almost 30% of our patients. LMA, that mask that sits above the vocal cords, we used in 15.4%, and we placed an endotracheal tube in only 11% of the patients in that 1,215 patient encounters. From an anesthesia risk in MPS, this is another study that I wanted to mention. This was just an overall review. They included 15 review papers, 17 retrospective case series, 5 prospective studies, and 28 case reports. And then this is a really nice summary of what we need to worry about as anesthesiologists when we take care of MPS patients. They start with the airway, mentioning a prominent mandible, immobile jaw, the large tongue or macroglossia, irregular shaped teeth, and narrow nasal passages. They also talk about musculoskeletal problems that Dr. White mentioned as well. A very short neck. Some of these patients will have the cervical neck instability. I know he mentioned that at previous places that he's worked, they don't have a concern about doing the flexion and extension when they do MRIs of these patients to look for that cervical neck instability. We at UNC do worry about that, especially when a child is under anesthesia, because they can't respond when it's uncomfortable. So we worry about the ability to potentially cause harm when they're under a general anesthetic and moving that neck. So we do hesitate to do that. These kids are going to also have enlarged tonsils and adenoids that we mentioned, tracheal distortion, and we'll talk a little bit more about that. Tracheal malacia, which I think Dr. Molbach talked about a little bit, but we'll show some examples of that in a few slides. Thickened and copious secretions. These patients can also have kyphoscoliosis or curves in their back, abnormalities in the shape and structure of their ribs. They can have obstructive pulmonary edema. They can also have compressed respiratory processes as well due to enlarged organ involvements in the abdomen and lots of airway edema secondary to recurrent infections or reactive airway disease. I like this slide because it really encompasses all of the things that we need to think about, including the cardiac manifestations when it comes to taking care of patients with MPS. The conclusion of this overall review was that anesthesia should be performed by a team with expertise in MPS disorders and in the use of advanced airway devices. This always reminds me of a case report that was in the literature about a patient who had a respiratory arrest that led to death when they went to a freestanding dental clinic for dental work. And in this dental clinic, they took care of an MPS patient, but they had no advanced airway equipment at that dental facility. So this just highlights the need to make sure that all the kids with MPS are at centers that have specially trained pediatric anesthesiologists because they can be very, very challenging to take care of. This is another study. This is a retrospective audit of anesthetic techniques and complications in children with MPS. This is a little bit old as well, but like I said, there's not a whole lot in the literature, especially when it comes to large cases. And this is only 17 patients. This is looking at patients from 1998 to January of 2011. And this was patients 2 months of age to 18 years old. They looked at 141 anesthetic encounters. They were specifically looking at cardiac involvement, and they found that 95% or 16 out of 17 had some type of cardiac involvement. This included about 82% of them having mitral valve stenosis or thickening. 18% had moderate to severe mitral regurgitation. 88% had aortic valve involvement, and one patient presented with dilated cardiomyopathy, which is very challenging to take care of during an anesthetic. And obstructive sleep apnea was diagnosed with a sleep study in about 35% of these patients. In this series, there was 20 instances of difficult ventilation or obstruction with the induction of anesthesia. A difficult mask ventilation was noted, 4.2% in patients status post a bone marrow transplant, 12.5 status post enzyme replacement therapy, and 27% about had no treatment and they had a difficult mask. You can tell that with a no treatment, sometimes the ability to ventilate from these patients can be even more significant. About 28% had an incidence of a difficult intubation. This was defined as requiring more than 2 attempts in a skilled, experienced pediatric anesthesiologist. The incidence increased by 19% with each additional year of age. I think it's very important to make note of. The older that you get, the more challenging these airways can become. There was a little bit less if these patients had enzyme replacement therapy. 1.4% was failed intubations, and 1.4 led to a trach postoperatively. Another study that I wanted to mention is airway management in patients with MPS, and this is the progression towards a difficult intubation. This was a retrospective review from 2012 to 2018, and this looked at 128 anesthetic records. 54 of these patients had enzyme replacement therapy, and 27 had bone marrow transplants. Mass ventilation, oh, I'm sorry, let me go back. Mask ventilation and LMA placement were not statistically more difficult in any age group. However, patients greater than 18 had the highest likelihood of a difficult airway, and it was 13 times more difficult. So the older you get, the more challenging this can become. Bone marrow transplant did not improve airway, at least in this study, and enzyme replacement therapy was associated with an increased risk of difficult intubation in patients less than 12, which was surprising to me when I read this article. What's really important to note, and that's part of the reason that Dr. Munzer and his team is doing this master course, is that it's not just the airway. You have to be concerned of multiple aspects of patients with MPS, including cardiovascular disease. This was looking at the histopathology of an 11-year-old child with MPS 7 in terms of looking at the heart disease. This specific case is an 11-year-old who presented for dental cleaning under general anesthesia. This patient presented with mitral insufficiency, and they were on enalapril to help treat that. On the induction of anesthesia, this child became unstable, had ventricular tachycardia, which led to a fatal ventricular fibrillation, and this patient died. They looked at the postmortem autopsy, and that's what they were presenting on. There were gross heart findings, including enlarged dilated heart, mitral valve prolapse, thick shortened chordae tendineae, and that's the kind of the strings that control the valves, thickened aortic valve cusp, and raised intimal plaques in the aorta. They also found that the coronary lumens were 40 to 70% stenosed, and those were composed of GAG deposits. And so I think it's really important to know that it's not just the airway. These patients, as that a few slides before, there's multiple things that we need to be concerned with. This study is looking at enzyme replacement therapy in cardiovascular disease. Out of 24 patients, the median age of the start of enzyme replacement therapy was 5.3, and there is 2-year duration, at least on average. Cardiovascular follow-up at 20 out of 24. They had 60% increase in valve regurgitation, 25% stabilization of valve regurgitation, and 15% improvement in valve regurgitation. This is a study by Dr. Munzer and his group. And what they concluded is enzyme replacement therapy does not improve cardiac disease if it already is present. And I want to talk a little bit about enzyme replacement therapy in the airway. This is looking at the slide to the left is some of the airway deposits that you'll see in patients with MPS. And this is airway after enzyme replacement. It may improve, but it will not normalize the airway disease that you see in patients with MPS. So I think pictures and videos are very helpful in terms of understanding some of this normal some of the airway anatomy. And I know you had some bronchoscopies from earlier today, but I just want to show you a few more. Um, this is that fiber optic scope. At the top of the screen, you see the base of the tongue, and then you see the epiglottis, that curved structure that leads into the vocal cords. We're going to go through the vocal cords and look at the trachea. What I want you to note is how wide open it is and how circular it is. We're going down to the carina, or where it bifurcates into the bronchus to get to the right and to the left lungs. This is a patient with MPS 2, and I want you to note the difference. See how crowded it is even to get to the airway, how much beefier or thickened that epiglottis looks, and then see how it kind of folds over. It's not as this shows a lot of signs of airway obstruction. When you get underneath that epiglottis, you're going to see those vocal cords and the arytenoids or those bumps at the end. There is a lot more tissue deposits there. This is a bronchoscopy of the exact same patient 5 years later. So, comparing that anatomy, you see even more crowdingness. You see that epiglottis kind of losing its integrity and flopping over and obstructing that airway. It's harder to get underneath it to actually see the vocal cords. You can imagine how this can be a very, very challenging intubation if you're just using one of those cameras that we talked about, as opposed to the fiber optic scope. So I'm so sorry I repeated that. This is 5 years later, and you're going to see that difference in the anatomy. Both of them were not great, but this one is definitely worse. And what I want to really point out is once we get into the trachea, which can be challenging, that normal airway anatomy, you saw how it was nice and open and nice and round. You're going to see flattening here. We call this tracheomalacia, where it's flattening out. And then when you get to the crina or you're starting to enter into the right and left, even the the bronchus are narrowed and more compressed. I think this is really interesting to take a look at because then it truly shows you some of the airway anatomy that we worry about. This is Morchio. This is NPS type 4A. This is the same patient. A is age 3, B is age 8, and C is age 10. This shows a tortuous trachea that leads to narrowing and can be very, very challenging to intubate. This is more common in Morchio than the other types of MPS, and it's kind of that twisting on itself, which is another very, very challenging thing that we can encounter when we're trying to take care of these patients. The take home point, I think, is pretty simple. MPS patients are at very high risk for anesthesia complications. Even looking at UNC, where we see quite a number of MPS patients, our anesthesia events are up to 23%. And that's in the hands of folks with a lot of experience. Elective studies and procedures should be performed at centers with pediatric anesthesia providers and physicians with advanced airway equipment. My personal opinion is that no patient with MPS should be receiving anesthesia at a freestanding dental clinic, at a freestanding ambulatory care center. All of the anesthesia, even if we think of sedation, as we talked about with the very beginning of this presentation, it's a continuum. And to get the studies that these kids need, often they're going to need a deep sedation, which means you need someone that can rescue these complex patients from a general anesthetic. And that needs to be at a specialized children's hospital. It's also very important to limit unnecessary anesthesia exposure. I love that Kim said that, even if she has to fight Cole, she does everything that she can to clean his teeth because she knows that every anesthetic and/or sedation comes with risk. Um, and that is all that I have today.